Hello friends, the topic today is endodontic emergencies. Starting with the introduction, it has been reported that nearly 90% of the patients seeking emergency dental treatment have symptoms of pulpal or periapical disease. Cause of dental pain is generally from caries, deep defective restorations or trauma. The aim of emergency endodontic treatment is to relieve pain and control any inflammation or infection that may be present. So 90% of the patients which are seeking dental treatment, especially in conservative dentistry and endodontics, are emergency treatment. Now starting with the definition, an endodontic emergency is defined as pain or swelling caused by various stages of inflammation or infection of the pulpal or periapical tissue. Okay, so it is related to either pulpal or periapical tissue. There are various stages, we all know that, like for inflammation, infection, various stages. It can be pain, it can be swelling, anything. It is considered as endodontic emergency, for which patient is eager to take any treatment. That is an endodontic emergency. Now, how to diagnose an emergency? First, take the history, location, duration, severity, aggravating factors of pain. We have already studied the history. Then pulp evaluating test, like thermal test, electric pulp test, direct dentine stimulation. Periodontal status we have to check with the help of periodontal probing, palpation, percussion, mobility, and bite test with the help of radiographs. These all help in diagnosing of any endodontic emergency. Then next is the classification of any emergency. It can be before treatment, under treatment, or post treatment. Okay. Now before treatment, obviously most of the patient fall in this situation, that before treatment they come as an emergency. It can be a pulpal because of irreversible pulpitis, acute periapical abscess, cracked tooth syndrome. And patient under treatment can be recent restorative treatment, periodontal treatment, exposure of pulp, fracture of root crown, pain as a result of instrumentation, acute apical periodontitis, phoenix abscess, iatrogenic it can be, some crown cutting must have been done that has caused this. Okay, and post endodontic treatment is high restoration, overfilling, underfilling, root fracture, anything can. So we will discuss each of the class in detail. Now starting with acute reversible pulpitis or hyperemia. Now what is reversible pulpitis? In the section of pulpal diseases we have discussed, it is mild to moderate inflammatory condition of pulp caused by noxious stimuli in which the pulp is capable of returning to uninflamed state following removal of stimuli. So what is reversible pulpitis? What happens? It is like some injury that has happened to your skin. It reverses back. It comes back to the normal texture when the stimulus is removed. Like you are hurt with something, and then if it is removed, then your injury will heal by itself. Similarly happens with the reversible pulpitis. Once the stimulus is removed, the pain will subside. But sometimes that pain is so severe that patient has to seek an emergency treatment for that pain. So this is very rare chances, but yes, there are chances in acute reversible pulpitis also that it can act as an endodontic emergency. Next is the diagnosis. How to diagnose it? We have to take the symptoms. Obviously, like it has to be sharp pain, non-spontaneous. Non-spontaneous means it is not starting with on its own. Some stimulus is there for it. Does not continue after withdrawal of stimulus, and the pain may be difficult to localize. You cannot localize the pain because we have discussed in the pulpal pathology there is no proprioception in the pulp. So the proprioception property, the localizing the proper pain is not in the case of pulpal pain. It is there in the periodontal or periapical. Now clinical tests, what we will do? We will check the vitality, sensitivity to temperatures like cold, hot, what the change is, and percussion, normal radiograph we have to take. Causes, it can be because of recent high restoration, fractured semen base, broken filling, marginal leakage, heat produced during cavity preparation, anything like chemical cleansing of the, and secondary caries. All these are responsible for reversible pulpitis. The management is removal of the cord, but obvious, place a pulp protective barrier. What it can be liner basis. Avoid marginal leakage. Any marginal leakage should be avoided. Relieve the occlusion if present, and avoid injuring the pulp with excessive heat while preparing or polishing a metallic restoration. And following that, you have to give a temporary sedative filling like that of ZOE or some calcium hydroxide. If it seems to be some kind of a very remaining dentin thickness is very less, then you can give some calcium hydroxide, so a basis form. And further, if the pain persists, you will go on for pulp extirpation if the pain doesn't get released. Now, next is the irreversible pulpitis. We all know it is the symptomatic, asymptomatic, and caused by a noxious stimuli. But after the removal of stimuli, the pain persists, and sometimes it can be lingering pain, and sometimes it is spontaneous pain. Whenever you remove the stimulus also, or without any stimulus also, it can start. So this is the difference between acute, reversible and irreversible pulpitis. Mostly in chronic diseases, this emergency doesn't happen. In acute diseases, the emergency is happening. Okay. Now again the symptoms: sharp, severe pain, spontaneous pain that lingers on, pain due to more due to cold, heated. Something like hot food, hot fluids, anything, and cold may relieve the pain, and it may radiate to other parts also. So, and what are the clinical examination we have to do? We have to do the inspection, vitality test, and our percussion, mobility, palpation, and radiograph you have to check. In radiograph, sometimes you may not see a definite involvement of pulp, but there might be some involvement, so we have to take care of that. Treatment is pulpotomy and pulpectomy. We have already studied the pulpotomy is the in posteriority only the partial part of the pulp is removed, and in pulpectomy whole of the pulp is removed. Okay. Now next is acute alveolar abscess. This is the image of acute alveolar abscess. It is the localized collection of pus in the alveolar bone, okay, and which results in the swelling. This will present as an intraoral swelling. Acute alveolar abscess. Again, you have to check for the symptoms. There will be throbbing pain. Throbbing pain is the what we can say major clinical feature or symptom for any pus. Okay, it may be chronic abscess, acute abscess. Any abscess will present as a throbbing pain. And elevated temperature, gastrointestinal disturbances, malaise, nausea, dizziness, etc. can happen. Now, clinical finding, you have to do the inspection. It will be a soft swelling. Vitality will give no result, no response. Radiographs you have to check, and the tooth should be tender to percussion. This is the important feature. There should be tenderness to percussion. Now, how is the management? It can be drained via the root canal space. Okay, so you can see in this image. It has been an access opening was done in the central incisor, and pus is draining from that, and this technique will give immediate relief to the patient. So you can give a open dressing also, and open dressing is just given for 24 hours. Earlier it was considered normal, but nowadays for open dressing you make the patient sit in the waiting area, and like for 20 minutes, half an hour, you let the pus drain. After that, you give a closed dressing. So this is a newer protocol given by American Association for management of any pus, management of any abscess. Okay.